Good morning. My name is Michelle Henry. Welcome to the Social Justice Forums. Our theme this year, Wading in the Water, Becoming Anti-Racism, is starting out this month with our session on health and public policy and racial justice. Helen Jackson-Lockett, L., will present her work on U.S.-born infant mortality and community engagement. Helen Jackson-Lockett uses a community-based model and has recruited groups, grassroots organizations, local and state organizations to become the Community Voices and Solutions leadership team. Her work on the infant mortality among U.S.-born African Americans in Hennepin County through a health equity lens has been the focus of her project. Please welcome Helen Jackson-Lockett, L.
Hello, my name is Helen Jackson-Lockett, L., Community Engagement Planner and Grant Manager at Minnesota Department of Health, the Center for Health Equity. I am the coordinator of a project at the center that focuses on infant mortality among US-born African Americans in Hennepin County, Minnesota. However, my work is not limited just to Hennepin County. One of the main goals of the project is to strengthen the capacity of US-born African Americans, the African American community, to change the conditions under which babies are born. We're going to continue to do it in a number of ways. And two of those ways are activating community to engage in an organized change effort to create change. The first one is Community Voices and Solutions, or commonly known as CVAS, our project leadership team, and that's the heartbeat of this project. And it leads to planning, implementing all the activities of the project. We have 19 members who are community leaders in their own rights and of various sectors, and also individuals who have a passion for seeing that the community have healthy babies. The second portion of our project is called Community Co-Learning Sessions, which recently completed two sets of cohorts of about 20 individuals who went through educational sessions and gaining understanding of structural determinants of health and how that impacts the outcomes of African American infant mortality, and to motivate co-learning participants to take action to change the policies and system that perpetuate infant mortality rates and disparities. I would like to share a few slides with you. Okay. During this presentation, my objective is to explain what infant mortality means and why it's important to all Minnesotans, and to give a snapshot understanding of infant mortality data and what contributes to health inequities in Minnesota. And lastly, to understand the basic premise of how Minnesota Department of Health works to advance health equity. First, I would like to just give a definition of infant mortality, because because many people say infant mortality, what that does mean? Well, the definition is defined as death of an infant before their first birthday. An infant mortality rate is defined as the number of deaths for every 1,000 baby born alive. And why is this a public health issue, infant mortality? It's because it's a sentinel measure of population health, and the health of the population or a community and the quality of their health care they receive is determined by the health of our babies. As we can see on this slide, the OECD, or the Organization of Economic Cooperation and Development, which consists of 34 developed countries, the data from the US Center for Disease Control show that for years 2015 to 2017, the infant mortality rate in the United States was 5.9. And a little closer to home, as we look at the infant mortality rate in Minnesota, we can see that that infant mortality rate is below the rate shown for the United States. However, Minnesota at a 5.0 infant mortality rate is the fourth lowest among all 50 states and was below the national rate. And it's also below the Healthy People 2020 target of 6.0. A closer look at infant mortality rate in Minnesota, it may seem like Minnesota is doing quite well, but when you take a closer look at the infant mortality rate by ethnic groups, race and ethnicity, we see that we're not doing well at all. 9.3 for African American and 10.3 for American Indians, compared with 4.1 for Caucasians. And this shows the number of births. This is how the mortality rate is calculated, live births to the amount of death that we experience in Minnesota. And we can see that it hasn't changed a whole lot in the last 16 years, according to this data. So we're still seeing over 300 babies dying before their first birthday in Minnesota. And even taking a closer look, when we talk about infant mortality rate for US born African American, we need to then take a closer look also of foreign born. And we can see from this slide that the percentage of births, that majority of those births are US born African American compared to those who are foreign born. And taking a closer look from a geographic location standpoint, we can see that the counties overall for the state, we see that's 5.1, but when we look at the counties, we see that both Hennepin and Ramsey County are experiencing a higher rate. Well, Hennepin County is the same as the state, but for Ramsey County, it's more. And that's why my work is not limited just to Hennepin County, but I try to collaborate with others in Ramsey County as well. And we look at infant mortality rate according to maternal age. And we can see that for those under 20, they do experience a higher infant mortality rate compared with 35 and over. However, when we look at non-Hispanic white, we can see that those rates, even for those age groups, are still much lower for other populations. One of the things that people usually ask, how is that related also to education? Because one of the things that we usually do in our presentation is inform our community that if you're an educated Black woman, your infant mortality rate is twice that or less than or higher, excuse me, for uh, a white female with less than a high school education. And we can see from the charts here that for an educated or someone with a high school education and above, their infant mortality rate is 6.5, while with a white with less than a high school education, there is also 6.9. So education doesn't matter when it comes to infant mortality rate for US born African American women. And many times individual will think, well, how about those people that, is it those individuals who are on Medicaid that's increased, that have those higher infant mortality rate? But we can see from the data that that is not the case. For women who are on Medicaid, their infant mortality rate is 8.7. But individuals who are not, are non-Medicaid, their infant mortality rate is 12.3. And again, infant mortality rate, according to the moms, we see African-American, US-born African-American women compared with foreign-born African women, we see that they have a much lower rate than the US-born African-American women. And that was the reason our project was focused on US born African American women. It's important to know the leading causes of infant mortality for the various groups. And many of the babies die during that neonatal period from 0 to 27 days after birth. And these are the top 4 causes in Minnesota based on the data 2012 to 2016, with the #1 cause comprising a little over a quarter of the infant deaths is prematurity. That's when pregnancy doesn't go full term and the baby is born before 37 weeks. A close second of 23% of the infant deaths is congenital anomalies, also referred to as birth defects. Next are sudden and unexpected death at 16%, and obstetric conditions or problems during pregnancy at 12.4%. And I put this slide in because as we think about infant mortality, we have to think about the various layers that influences health outcomes, and this happens to be one of them. As we look at it, we see that the individual life factors, the age, sex, etc., social community networks, and then the general socioeconomic, cultural, and environmental conditions do play a role in infant mortality. And we'll talk about that a little more as we go through this presentation. One of the things that we're looking at is the stressful life events that women, especially US-born African-American women, encounters during their pregnancy. And we can see from these charts, the different categories of stressful event that occurs prior to the birth of a baby. And we can see moving, US-born African-American mothers are 41.6%. American Indians, the indigenous population, is also plagued with similar outcomes. And one of the things that we're doing is not only doing it within the African American community, but laying a model that we will be able to use later in the American Indian community also, because they're experiencing similar things. As we can see, problems with paying rent, mortgage, and other bills, we see that 28.8% of individuals are faced with those conditions. So these are all stressful events that impact birth outcomes before and during pregnancy. And this is showing other stressful events such as a husband or a partner or job loss. And I hate to read the figures because you can all see it on your own, but take a look at those numbers. When you talk about partner cut in the work hours or pay, we're talking about 25.2% of individual. Loss of jobs, we see again, US-born African-American women experience has a greater percentage here, even though they wanted to go to work. Well, what this leads to is really health inequity. And health inequity is a type of health difference that is closely linked with social, economic, and environmental disadvantages. Health inequities are inextricably linked to structural inequities and adversely affect groups of people who have systematically experienced greater obstacles to health based on their because of race or ethnic group, religion, socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, or other characteristic historically linked to discrimination or exclusion. And I'll let you read that. What is health equity? You hear people talk about this a lot. Just study that slide for a moment. And you can see from that slide, you know, we talk a lot about equality, but if we look at the first row, we see that when we talk about equality, where everyone is receiving the same treatment, that it still leaves individuals out. We see the disabled individual that they're not even able to get on the bike. The little kid, he has too big of a bike. But when we talk about equity, what we're doing is making it fit the situation that the individuals are facing at that time. Equity is giving everyone what they need to be successful. Equality is treating everyone the same. Equality aims to promote fairness, but it can only work if everyone starts from the same place and needs the same help. Personal responsibility does play a key role in health, but the choices we make depend on the choices we have available to us. We must work together to ensure that everyone has the opportunity to make healthy choices and to achieve better health for all. The World Health Organization gives a definition of health equity. And also from the Minnesota Department of Health, Advancing Health Equity in Minnesota, from the report from the legislature in 2014, Health equity is a state where all persons, regardless of race, creed, income, sexual orientation, gender identification, or age, have the opportunity to reach their fullest health potential. And that's what we want. That's what we need. When every person has the opportunity to realize their health potential, the highest level of health possible for that person, without limits imposed by structural inequities, that person will succeed. Health equity means achieving the conditions in which all people have the opportunity to attain their highest possible level of health. And this is a pie chart created by the World Health Organization. When we're talking about health, we think more on the individual's behavior and health care. But if we take a closer look at this, we see that social and economic factors is 40% of what determines if someone is healthy. Then when we include the physical environment, that's 50%. So, you know, a lot of times people say, well, why can't someone do this? Or why doesn't the mom get her prenatal care? Or why doesn't this happen? But all these other factors, because they play a role, influence the outcome of that mom, and not only the mom, but also the baby. When we think about this great state of Minnesota, we are ranked 4th overall for health among all 50 states, and ranked number 2 as America's top 10 healthiest cities, this listed in 2016. Unfortunately, here in Minnesota, even though that's very promising and looks great for other communities, that's not the case. And when we're talking about Minnesota being healthiest, it's healthiest for whom? American Indian and African American babies die in their first year of life at twice the rate of white babies. Lesbian, gay, bisexual individuals have the highest rates of binge drinking of 26%. AAPI, 4 times more likely to have liver cancer and 2 times more likely to have stomach cancer than whites, and higher likelihood to die from cancer due to lack of preventative screening. African Americans and Hispanic are less than 10% of Minnesota's population, but have half of all the HIV infections. And American Indian youth dying from suicide 10 times more often than other young people. And 10% of youth and adults are obese, but rates are higher among LGBT and American Indians and Hispanic young adults, youth and young adults. So when we're talking about healthy for who, it may seem that Minnesota is doing well, but when we look closely at the other numbers, the other groups that are impacted are not benefiting from these numbers. And this information was from the 2017 statewide health assessment. Within our community, we see a lot of structural or systems of society, such as finance, housing, transportation, etc., that they're structured in such a way as to benefit one population unfairly, whether or not we want to hear that or think about that or not. And unfortunately, that is the reality of Minnesota. And because of those structural inequities, it does impact people of color and the indigenous population more, and then that impacts the health of the babies. As we saw in the very first slide, that the health of a community and the health of our state depends on the health of our babies. And if our babies are not healthy and the babies are dying, then that says that our community, our African American community, and our indigenous population are not benefiting, are not having good health, and not benefiting from some of the things that are available in the state. In August of 2017, this was a CBS news story. Blacks are 10 times more likely to end up in prison or jail than white. And we can see what's happening in our state and across the country. So we know that that's a fact. Median income for Black people in Minnesota is less than half that of the whites. And you can see those. And then when we talk about home ownership, Blacks are less likely than a third of the rate of white people in terms of home ownership. And Dr. Rachel Hardiman from the University of Minnesota writes, and this is taken from one of her slides, that structural racism is normative, sometimes legalized, and often manifests itself as inherited disadvantage. And what is your role in health equity? One of the things that we need to think about as a community is what opportunities have enabled us to create and define what is optimum health for ourselves, but also what we need to think about is how will we provide opportunities for others to create and define their health. Having the places and spaces you have lived allowed you to thrive. How will you create spaces for others to feel that they belong and have the opportunity to thrive? We're talking about your role in health equity. And sometimes when we think about health equity, we don't think about places and spaces and opportunities, but all those impact our health outcome. Those social determinants of health are very strong and determines the health of mother and child. What experiences have told you that you belong or do not belong? In what ways are you telling others that they belong or do not belong? And I'm just having you to stop and think about that for a moment, that you do have a role that you can play in advancing health equity. And I'll be talking in a moment about what we're doing from the Minnesota Department of Health to advance health equity. But each of us have a role to play to provide opportunities, spaces, and be inviting so that others feel that they belong. And I mentioned at the very beginning that I am from the Center for Health Equity, and just wanted to tell you a little bit about what the center is. It's a current evolution of the former Office of Minority and Multicultural Health that many people may be familiar with. And it was established by the Commissioner of Health in 2013 to bring an overt and explicit focus to the efforts of Minnesota Department of Health to advance health equity. The Minnesota Department of Health vision is health equity in Minnesota, where all communities are thriving and all people have what they need to be healthy. As I stated, over the years, Minnesota have been gleaned as a place where everyone is healthy. But when it comes to people of color and indigenous population, we are far away from that. Our mission for For the Center for Health Equity is seen here. It's to strengthen, to connect, strengthen, and amplify so that we are providing that force or that background for everyone so that they can all be healthy. And there's our statement again for our mission. And our mission is grounded, as you can see by this tree that represents our department, that we honor cultural knowledge and wisdom, we foster trust and belonging, and recognizing that health equity as a human right, and that it's important to listen deeply. And resilience, intersectionality, network leadership, racial equity, community-driven data solution, systems that heal and not harm is the way we go about our mission at the Center for Health Equity. Within our department, we're doing a lot to advance health equity. Internally, we have what we call high health, internal health equity advisory leadership, and they convene from each of the various areas represented, represent the different departments at the agency, and they meet together to help to streamline and coordinate and foster health equity work throughout the agency. On a regular basis, but we have been stopped by COVID at this moment. We we have champions that are working towards health equity, and we recognize those individuals and highlight their stories and their programs of how they're doing that within the agency. We provide technical assistance, community practice, training, and then we provide equity grants. And you may be familiar with some, the Eliminating Health Disparity Initiative, Community Solution Fund to promote healthy child development. There are different grants that we provide throughout the year that goes toward helping to make health equity a standard in our community. And in our community, we, you can see some of the things I just mentioned: the Community Solution Fund and the Eliminating Health Disparity Initiative. And then we have other leadership group like the HEAL Council. It's an advisory council that provides feedback and information to MDH and to our commissioner on systems and policies that's needed to make sure that we are working in equitable ways, not just in the metro area, but across the state. And these are just some resources. If you ever need to get some additional information, please feel free to contact me and I can share these at another time or share with the facilitator of this program. But we should always remember that all babies in Minnesota deserve a healthy start and opportunities to survive, thrive, and develop to their fullest potential. And the only way that we can do that is being equitable in our approach of how we address pregnant moms and their families. Because if we don't, if we continue to have these high rates of infant mortality, then again, our community is also very unhealthy. So how can we all make sure that all babies in Minnesota deserve a healthy start? Is by doing our part to make sure that we are contributing to health equity solutions. Thank you. And this is my contact information. Please feel free to call or email me at your earliest convenience. Thank you and have a good morning.
Questions for you that we've developed, and I wanted to know if you would have some time to go through some of them.
Yes.
So, can you elaborate further on the obstetric conditions that you identified earlier in your slides? Does substance use, for example, of the mother play a role in healthcare disparities in U.S.-born African-American infants more than other populations or ethnicities?
I'm glad you asked that question because yes, in the state of Minnesota, we do have high rate of opioid use. I don't have the data at the moment for African American moms that do use opioid or are addicted to drugs. However, one of the things that happens as mom goes in for delivery, that they're automatically assumed that they're taking some drugs. And we have heard stories from individuals in the community who have been accosted for and threatened to have their babies taken from them if they did not submit to a test, even though they were not using any kind of substance. They were not experiencing any substance abuse. So that's one of the things, unfortunately, that happens, is that those individuals, everyone is put in one group, and you're immediately considered a suspect if you come in and have your baby in a short amount of time. Then your baby, then you're automatically assumed that you were using drugs. Yes, that is an issue. And people who do have problems with drug abuse do tend to have smaller babies. And some of the obstetrics that's listed as one of the leading cause, it may not be just a drug. It could be some other things that's going on with the patient-doctor relationship or midwife. So it doesn't always have to be from drug, but it's assumed a lot of time that is from drugs.
I mean, that's very sad. So I work as a nurse practitioner, and when I'm working at work, we do get a lot of pain consults on the obstetrical unit, not because of people of color, but those with substance use, right? I know there's other obstetrical conditions, and it's very unfortunate that people are labeled. That's more of like a systemic racism, isn't it? And that's very, very sad, and we need to work on reducing that. You mentioned other stress factors, such as job loss or other socioeconomic hardships as playing a role in infant mortality. Have you measured recently an increase or a change with infant mortality during the pandemic?
No, we would not have that data at the moment. But I'm working on another project in terms of homelessness. And in 2019, we had over 300 babies that were born to mom who were in homeless condition, in unstable or environment. And this was like over 300 babies that were born in that situation. We don't have the data at the moment, but I'm sure it's being collected. Definitely because people are being impacted by COVID in a lot of different ways, and there are different layers that impacts those outcomes also. One of the things I know that's happening is their support is not there because the hospital limits the amount of individuals who can come in during the time of delivery. So sometimes not even the doula can go in, but I think for some place they are allowing at least the doula to go in. But if there is a spouse or some other significant other, sometimes they would like to go in. And so then the doula is not there to give that support at this time during COVID. So some of that support is missing during COVID. How is that impacting moms and families? We don't know at this time. I don't have that.
Well, that will be interesting to track that later, I think, when that
Yes,
data
it
comes
would be.
along. One question that was raised by one of our audience members was the relationship of nutrition to maternal, child, infant mortality and health, and ways that churches can possibly get engaged in facilitating improved nutrition.
Well, definitely nutrition does impact birth outcomes, and it's important for women to begin early prenatal care, and so that they can get the so they can get the nutrients and the vitamins and additional things that's needed for a healthier outcome. Um, I was thinking I did not put that slide in, but one of the things that we do see is majority of the women seem to be coming in early for either in the first or second trimester to access healthcare, and so that does help. But poor nutrition, just as how it impacts a non-pregnant woman, it will definitely impact the birth outcomes. So trying to think of how can the church help? I would have to give that some more thought. Definitely, maybe many churches already have food shelves, but sometimes those food shelves provide more canned goods than fresh fruits. So one thing that I know that's happening at Nord Point is that they have once a week where they're providing fresh produce for families. And that's one way to encourage healthy eating. So that could be one way of maybe providing healthy food and maybe produce instead of just canned goods. I know that's limited here in Minnesota due to our weather, but that would be one way of doing that.
Okay, thank you so much. Are there other community organizations that you're aware of that would kind of reduce or support health equity across the board, in particular, I guess, people of color?
Yeah, there are several other organizations, as I mentioned at the beginning, that even though my project was specific to Hennepin County, I do work with Birth Equity Collaborative Council and ICHIRP, which is Integrated Care for High Risk Pregnancy and Prenatal to 3. There's several organizations and several groups that are working not just in Hennepin County, but both counties, both the metro seven county metro area, that's addressing infant mortality and low birth weight. A lot of times we speak more about infant mortality because we were looking at deaths before their first birthday. But when we're talking about, and we see from the four causes, major causes of infant death was prematurity. And so some groups are working on some groups are working on low birth weight because there's so many different things that contributes to the low birth weight. And so the woman is not going full term. And so it's less than 37 weeks. And because of that, the infant has not developed enough and a lot of times end up in the NICU, neonatal intensive care unit. And one of the things we're trying to encourage women to do is to go all the way, encourage them to keep the baby to full term. But sometimes because of the stress, some women end up going into labor earlier because of all the other stressful things that's happening in their lives. And with such instability, it does end up impacting the birth outcome.
Thank you. So you addressed the multiple factors on one of your slides, such as socioeconomic factors, self-determination, or lack of health care access as risk factors. Is there a multi-prong approach that you are suggesting would help, and how can faith-based organizations be involved in that in helping dismantle systemic racism?
Oh, that's a big question.
Maybe I should get on your staff.
Yes, yes, yeah. Definitely multi-pronged because, as I mentioned, there's several things that impact birth outcomes. So transportation is a big thing. One thing, if the church would like to do that, maybe connect with a clinic and see how they could maybe help to provide transportation. A lot of times, individuals may not have the transportation they need to get to their appointments. And if I have to work and I have a doctor's appointment, that means I will need to take off work, get on the bus, get to the appointment to come back, and sometimes then get back to work. And that's not always feasible. If they had transportation, maybe they would be able to do that. So sometimes people may miss the appointment because they don't have transportation or reliable transportation. So that's one way, one thing to do. One thing I mentioned also, which is a big problem, and it's bigger than myself, is the homeless situation. Affordable housing is such a problem in the city and in the metro area. We are definitely building new housing, but they're not affordable housing. So one way, how do we provide more affordable housing? Another, as we're talking about multi-prong and talking about housing, one of the projects that our co-learning community group did was to look at maternity homes. A lot of we were able to find about 4 in the metro area. Most of those were faith-based, and they provided housing for women during their early pregnancy and through the postpartum care, and at the same time laid a foundation for them to have stable housing later on. And so that's one thing. They need to be more, maybe some more maternity homes, but they also need to be culturally appropriate, so that they include some of the resources and things that would be helpful for the moms. including maybe doula and also postpartum. A lot of times, individuals are facing mental health challenges due to postpartum depression. So there are other things that maybe the faith-based organization could help with. And it is multi-pronged. There is no way to say that it's just prenatal care, it's just housing, or it's just transportation, or it's just employment, or it's just environmental factors. So that's why it's such a challenge to address infant mortality, because it needs to be multi-pronged. And if you fix one end and the other end is left out, then we sort of have a lopsided way and don't get very far. But one of the most important things, though, that faith-based can do is to look at the policies that impacts moms, and not just moms, also the fathers. One of the things that we did in our project was to be very intentional about including men. The myth out there is that a lot of time African American men are not involved with their children, and that's far from the truth. A lot of men are very much interested in being a part of the process, but a lot of times when they go to the visit, prenatal visit, everything is directed at the mom and nothing is done for the father. So we were very intentional about including men in the conversation and to see their roles, because they can encourage mom during pregnancy of making sure that she's eating right, and encourage her in breastfeeding and other things that would be beneficial to the baby after the baby is born. But definitely to address some of those policies, to see how some of those policies are impacting women and families, and help to maybe get on the legislative agenda. You know, one of the things that's still leave of during pregnancy, paternity and maternity leave, some places offer it and some don't. And also, how do we increase minimum wage? All those things impact, even though they're not directly, but they're indirectly affecting some of those things. And when we also look at mental health, there's also a lack of practitioners for mental health. How do we engage more mental health practitioners, cultural specific mental health practitioners? How do we support doulas? How do we support education for midwives? You know, there are different ways that maybe scholarships or different things that could be done to encourage individuals to go into midwifery or nursing or other things. Maybe offering scholarship to people of color and indigenous individuals so that they can get that education. I'm just throwing that off at the top of my head.
Well, thank you
Perspectives.
so much, Helen, for all of your insightful wisdom and remarks and prodding and opportunities to be engaged. We greatly appreciate your time, and thank you, Michelle, as well. Next week, we will welcome Sharon Day. She's a member of the Boisfort Band of Ojibwe, and she's a water walker. Her talk will be Water Walkers, Creating a Revolution Based on Love, and talking about the importance of protecting our precious waterways. Please join us then.